Uh, uh, it's always nice to be in Varanasi. It's like a second home to me. I've been here since 2017 when the railway hospital was there, and then we brought it down, and then we constructed the HBCH Varanasi. And every time I come, I see more improvement and more augmented infrastructure, which makes my heart wonder. So now coming back to what is a resource constrained setting, uh, we have to look at what are the minimum requirements of a transplant unit. Now, when we look at the minimum requirements of a transplant unit, it's not something dissimilar to what we see in the West. But keeping in mind that the low middle income countries may not have all the resources which the high income countries have, these are some of the essential things that resource constrained country units should have. So first and the foremost is to have a very clean BMT unit environment. Then of course you need the hematologist or the medical oncologist trained in transplant. We need excellent nursing staff who know how to take care of these sick patients, a facility for cryopreservation, a 24-hour transfusion medicine department. So I can tell you from my own experience, when we started building the unit in ACTREC, I was told that the blood bank only works till 5 p.m. So I told them that if it works till 5 p.m., then I'm sorry, I'm not running this unit. Because you can't have a blood bank running only till 5 or 7 p.m. It has to be 24 hours. And this is a complete, for all the youngsters here, it's a complete no if anyone tells you in your institute that it should only run for 12 hours. 24-hour microbiology and biochemistry department, a 24-hour pharmacy. Again here, when I joined ACTREC, the pharmacy was only open till 7 or 7:30. And it took me some time to make it work for 24 hours. A good hematopathologist, a good relationship with allied branches, and above all, the skilled personnel should have the passion to run such intensive areas. It's not an easy task, especially when you build one from scratch. And unless you have the passion to make it work, it doesn't happen. The last one was the leadership. The leadership should be supportive. And we've been lucky. The leadership at Tata Memorial Center, Mumbai, was very supportive of the transplant unit. And similarly in Varanasi, we only succeeded because the leadership was very supportive. Now, what's the status of transplant in the country? We have around 105 centers, probably 120. Some of the centers don't submit data to the transplant group. And now what we have is formal structure with the which is known as the Indian Society of Blood and Marrow Transplant since 2019. And that is what has made it now a more formal structure. Now, why I'm showing you this slide is because it has bearing to how we will choose patients. Now look at this graph. In 2020, we have 105 centers, but in 1983, we had only one, and we were the privileged one to start it in Mumbai in 1983. For the first decade, there were just 3 centers, Tata, Vellore, and AIIMS. Then the second decade of 1993 to 2003, there were another addition of 8. And from 2003 to 2013, an addition of 26 centers. Very slow. But look at the explosion between 2013 to 2020. There are more than 70 centers which have come up. Now, it would look as if this is an explosive rise, but to be honest, for a country as large as ours, this is a very slow growth, and I'll tell you why. So overall, we've done some 21,000 transplants across the country, or slightly more because some centers don't give us data, till 2020. Now, 20,000 transplants are done in a single year in many of the developed countries. And we took some 40 years for 20,000. So that's one thing which we should look at and introspect, that obviously we are way behind what the rest of the world is doing. Now, there is a parameter which is known as the transplants per 10 million population, which is known as the transplant rate. And in this, if you calculate that we do 2,000 transplant per year in an average, and we have 1,300 million population, so we are doing around 15 per 10 million population transplant currently. Now, what are the indices in the developed world? In the developed world, number of transplants per 10 million is more than 300. So if we were to do more than 300 transplants per 10 million, then we should actually be doing around 40,000 transplants per year, which is nearly as many as what the United States of America does or the whole of Europe does. And what is the gap? 40,000 and 2,000. So we have a gap of 37,000 transplants or 38,000 transplants, which means these are deserving patients who need transplant, but cannot undergo transplant, A, because probably there are not enough centers, B, because they don't have the resources to undergo transplant, and of course, the government is not being able to help. Now, another index is the government expenditure on health per capita and the rate of transplants in different countries. So if you look at that graph there, as the government expenditure on health per capita increases, the transplant rates in that country increases. So those who have low government expenditure on health, they have lower number of transplant rates, and those who have high, they have higher. So India spends around 3% of its GDP, the US spends around 16%, and the average in the world is 10%. Now, the government expenditure on health per capita is $65 for India. It's $10,000 in US and an average of $1,500 in the world. So we are way below even the average in the world for the amount of expenditure on health per capita. And this is the most important, out-of-pocket expense. In India, 50% or more is the out-of-pocket expense for the health care. In US is 11, and the whole world is 18. So when you look at this, you already know how on earth can we do transplants for a large majority when the expenditure on health by the government is obviously not enough, and the out-of-pocket expense for the patients, half of it is from their own. Another important part is the transplant team. Now, this is the FACT-JC accreditation, which is just like the NABH accreditation in our country. And this is an international body which accreditates centers across the world. And in their own criteria, they need at least 2 transplant physicians, one as a program director and one as another consultant who can supervise a small unit at least. Now, many centers in our country is run by only one transplant physician. We are lucky that we have a large group of people who can do transplant, but that is because we are an academic institute of excellence. But many of the other centers just have one transplant physician. So with one transplant physician, you can imagine what it would be. And that is why we have to then choose our patients wisely, because if we don't choose them wisely, there are very high chances that you will be frustrated. Now, what are the indications of transplant in our country? This is our data of 2020 from 1983. And with 21,000, the most common indication is myeloma in the auto transplant. And the second commonest is acute myeloid leukemia. And this is the same as if you look in the world. In the world, the myeloma transplants are the commonest auto transplant indication, and acute myeloid leukemia is the commonest indication across the world. There would be some regional differences, and this is exactly what we see in our country. So what are the factors affecting outcomes post-transplant? I think the foremost is patient-related and the disease biology. They basically interact with each other. And that is what I'm going to focus in the next part of my talk. The type of donor also has a role to play, but that's not what I'm going to discuss today, which means whether it's a matched sibling or whether it's a haplo or whether it's a mud, source of stem cells, whether it's a peripheral blood, marrow, or cord, and conditioning regimens used also probably have some role in affecting outcomes. But the foremost are the patient-related and the disease biology. So one of the most important index that tells you whether this patient is going to do well or not is what we call the hematopoietic cell transplant comorbidity index. Now, this is derived from the Charlson's comorbidity index, which was conceptualized probably 45 years back, where it was not only meant for malignant diseases, but it was meant for other diseases also. The transplant fraternity adopted the Charlson's index and made it more refined. And this index came out from the mecca of transplant in the world, the Fred Hutchinson Cancer Center. And this was a 2005 index in which you can see that each of these comorbidities are given a score. And you can see that the worst scores, the higher the score, the worse. The worst scores are cardiovascular disease, pulmonary, and hepatic. Now, this is a long list, but it's just to say that according to the comorbidity of the patient, you can score them, and you add all the scores according to the number of comorbidity the patient has, and then come to a total one. Now, this has been augmented. The initial comorbidity index did not have age as a factor. So age has been added as score 1, and that is if it's age above 40. And then albuminemia, thrombocytopenia, and hypoalbuminemia has also been taken into it. So what does this comorbidity index do? It stratifies very nicely the non-relapse mortality. And as the score rises, your non-relapse mortality, that means transplant-related death, is increasing. So if you look at the score, you will see if you had a score of 0, that transplant-related mortality was 10 to 15% in allogenic. And if you have more than 3, it is around 40%. And then, of course, then the survival again will then depend on what's your index. Now, this was modified, adding age above or less than 40, and that score was 1. And then when you looked at this, it further refines the stratification. And here you would see that score 0, 1 to 2 have less non-relapse mortality. As you go to 3, 4, and 5, it rises. So that takes care of the patient-related problems, the comorbidity. But then another important component is the disease biology. How do you capture the disease biology? Now, if the disease risk is high, the relapse will be high. But that will also have an overbearing on the survival. The overall survival will decrease because you'll have more relapses. So again, the CIBMTR, the largest registry in the world, where they take all the transplant data from many countries across the world, they came up with this sort of a table where they try to classify each disease into 2 parts. The inherent risk of the disease to relapse, and that is the disease risk, and the status at transplant. When you combine the inherent disease risk and what is the status at transplant, and then you have a score in which you will either say that the disease risk index is low, intermediate, high, very high. And look at the graph here. Both the progression-free survival and the overall survival is much worse when your disease risk index is very high compared to the low and the intermediate. And why I'm showing you this is this again will tell you how to select your patients, especially in a resource-constrained setting. If you take the very high disease risk index patient, the survival is anyways poor. And what you will do is probably not take, you will neglect a patient who has probably a low and intermediate risk for which the patient anyways would have done better. Now, this disease risk index was refined in 2014. In particular, I'm not completely happy with this index because I still feel there are caveats in this. But anyways, this is the best we have right now to find out what is the risk of relapse. And this is the new index modified with some disease status being changed. But again, it tells you the same. Now, there's an online tool for this. And we do that in ACTREC, we look at the online tool, we put the data for the disease, and the disease risk index comes. So we know what are we dealing with. However, the score which I like best is an amalgamation of the risk of relapse and the comorbidity of the patient. And this is exactly what it is. You have the age of the patient as a patient-related factor, and then you have the disease-related factors and the donor type, and whether it's a female donor to a male patient. And this is the EBMT score, which tells you that if your score is 0, you will do very well. If your score is 7, you will do very poorly, and the transplant-related mortality would be very high. And this is the amalgamation. Now, these three index cannot live independently. They have to marry each other to make it more robust for any patient, any transplant physician or team to understand what they're dealing with. And this are composite scores, again, combining the comorbidity with the EBMT or with other factors to give you some sense of what will be the outcome of a patient who needs transplant. So this way you will know which patients you need to take in a resource-limited setting and which patients you shouldn't. Now, the last part of my talk will be for few cases that I've taken where we went wrong and few cases where we went right. So this is a 54-year-old male CML with CP. He converted to blast crisis, was given CLAG with ponatinib, achieved CR, planned for transplant. He had major comorbidities and the lung function was severely compromised. EBMT score was 5 out of 7, comorbidity index was 3, disease risk index was high. So obviously we knew that we were working with someone who has a high risk of relapse and high risk of TRM. So it was a matched sibling transplant. We gave non-myeloablative regimen because obviously the full intensity or anything more than that would have been worse. And look at what happened. Developed GVHD, sepsis, TTP, and he succumbed. Case 2, a BALL in CR3. Again, had many times been treated, had relapse twice, had CNS involvement. The lung function was very compromised. EBMT score 4 out of 7, morbidity score 3, DRI high, high risk of relapse and TRM. And what was the cause? Again, it was a sibling transplant, relapsed within few months. The third is a progressive NHL, did not achieve a complete CR before transplant, had received salvage therapy. This was the time when Nivo and Pembro were not there. And then within 3 months relapsed. So these are patients probably we should not take in our resource setting. We did it and we burnt our fingers. Now, this is a classic case of a T315I CML who was not achieving a molecular response, was in CP when he also relapsed, and an HLA matched sibling. The score was 3/7 EBMT, comorbidity 2, DRI low. And we are transplanted him, and more than 9 months, he's good with some GVHD. An ETP-ALL, again, we took in CR1, because it was an ETP-ALL, EBMT score 1/7, comorbidity 0, and disease risk intermediate. A fully matched sibling, and she had a VOD, she came out of that, and she is in CR, more than a year. And this is a primary progressive lymphoma, again, received salvage, went into CR, went for auto transplant, more than disease-free 3 years after transplant. It was a primary progressive who achieved a CR. Now, this is the last case where I would say we don't know what to do. A CML-CP has become a blast crisis despite all the treatment, and now has leukemic deposit in the orbit. And we were thinking whether to do transplant or not. And when we looked at the indices, it's 6/7 EBMT. And that tells you that probably it is not the best thing to do for this patient. And in our meeting last week, we decided not to do. Transplant versus no transplant, at least to me, it's no transplant. We will be just wasting resources. So this is the HBCH Varanasi. We have a transplant unit of 8 beds, and it's fully functional. We've done more than 37 transplant in the resource setting that we are, with 0 100-day mortality. It's predominantly auto with 2 allos. And this is the team which makes it work. The local team with Sujit and Anil and the nursing team, and the team which comes from